Hello and welcome to Chapter 17, Respiratory Emergencies for the EMT. So in this lecture, we're going to talk about respiration, breathing difficulty, respiratory conditions, inhalers, and nebulizer treatments as well. So respiration, respiratory anatomy and physiology. The diaphragm is that muscular structure that separates the chest cavity from the abdominal wall. And during normal respiratory cycle, the diaphragm and other parts work together to inhale and exhale. Okay, so we've got the diaphragm down here. Okay, this is in the relaxed. This is the process of respiration. When it's relaxed is when we're inhaling or exhaling. I'm sorry. So it relaxes and we creates the positive or the negative pressure to inhale. Okay. Inspiration is the active process, uses muscle contraction to increase size of chest activity. Intercostal muscles and diaphragm contract. The diaphragm lowers, the ribs move upward and outward, and the air is pulled into the lungs. Okay, set negative pressure. Expiration or exhalation is the passive process where the ribs, muscles, and diaphragm all relax. The size of the chest cavity decreases and air flows out of the lungs. This is that positive pressure process. Breathing sufficient to support life is adequate breathing. Okay. If you don't have adequate breathing, you don't have life. So let's talk about signs of adequate breathing. So no obvious distress. They have the ability to speak in full sentences without having to catch their breath. They have normal color, so pink, warm, and dry. And they have a normal mental status, so whatever's normal for them. Of course, we talked about some patients that may not have that normal mental status on a regular basis. They may only be like alert to their own person and maybe place. Sometimes they're only alert to who they are. And then orientation. So this may be determined by observing rate, rhythm, and quality. Okay, so 12 to 20 breaths per minute is normal for an adult. 15 to 30 is normal for a child. 25 to 50 is normal for an infant. The rhythm is usually regular, unless they know that you're taking the respiratory rate, then they will have a regular rate. So they'll breathe in, they'll exhale, they'll breathe in, they'll exhale at a regular rate. Breath sounds are normally present and equal. Okay, so let's talk about inadequate breathing for a minute. It's not enough to support life. It has an irregular rate or irregular rhythm. The rate is out of normal range, so it's higher or lower. They may have some diminished or absent lung sounds, and they also have a poor tidal volume, meaning that they can't fully get a full breath in. So on a pediatric note, the structure of an infant's and child's airway differ from that of an adult, which we've talked about previously. So the big things is that the airway is smaller. They have a larger tongue than we do proportionally. They have a softer, smaller, more flexible trachea. They're less developed in their cricoid cartilage, which is that cartilage that runs along the trachea. And then heavy dependence on diaphragm respiration. So signs of inadequate breathing in infants and children, you're looking at nasal flaring, grunting, seesaw breathing, and retractions. Inadequate breathing for anybody. what we're going to do is we're going to assist ventilation with supplemental oxygen, which includes like a pocket mask with supplemental oxygen or the 2 rescue BVM with that oxygen. Chest rise and fall should be visible with each breath when we're giving artificial ventilation. So when we do ventilation for an adult, we're aiming for 12, okay, breaths per minute. When we're doing children, we're aiming at least 20, if not more, for the smaller infants. Okay, this range right here, this 12 to 20 range, is a good range to keep in mind when we're doing that. Okay, so increasing pulse rates can indicate inadequate artificial ventilation in adults. So if they start to become a little bit tachycardic, what's the body trying to do? It's trying to get rid of the carbon dioxide. So if it's trying to pump blood and get the oxygenated blood where it needs to go instead of getting that carbon dioxide out, then we're not adequately ventilating our patient, and we need to fix something. Okay, decreasing pulse rates can indicate inadequate ventilation in pediatric patients. Okay, so it's the same concept. It's just that their bodies are a little bit more adept at compensating than ours are. So how much you recognize the progression from adequate breathing to inadequate breathing in the assessment of your patient, and how might you change during this transition? So you can recognize the progression from adequate breathing to inadequate breathing in the assessment of your patient by looking for those clues of inadequate breathing. Okay, so you're looking for cyanosis, you're looking for harder work of breath, you were looking for rhythm, rate, breath sounds, and everything like that. Okay, so then how might your patient change? So we talked about that. Okay, so their breath becomes irregular, they have diminished or absent lung sounds, and they have a poor tidal volume. So they're either breathing really, really shallow or they're breathing really, really deep. Okay. Breathing difficulty. This is the patient's subjective perception of their difficulty of breathing. Okay. Feeling of labored or difficult breathing. Amount of distress felt may or may not reflect actual severity of the condition. So they may not be as distressed, but yet the severity of their condition suggests that they are in a huge amount of stress. Like they're not getting the needed oxygenation, and they're not getting rid of the carbon dioxide that they need to get rid of. Okay, so this tripod position here, where he's got his arms down on his knees and he's resting them, and he's kind of leaned forward just a little bit. He probably meets the criteria of breathing difficulty. Okay, he appears that he has breathing difficulty. Okay, so what questions do we want to ask? We want to use the OPQRST mnemonic, and we want to ask, when did it begin? What were you doing when this came on? And do you have a cough, or are you bringing anything up with it? Okay, so quality, provocation, onset. Radiation. Do you have any pain or discomfort anywhere else in your body? Or does this pain, if you have pain, seem to spread to any other part of your body? Severity and time on a scale of 1 to 10. How bad is your breathing difficulty? Okay. And how long have you had this feeling? So we want to observe for altered mental status. Barrel chest is where You see patients, if you go out to like Walmart or McDonald's or anything like that, you'll see patients that have um, a a barrel looking chest, and it's normally bigger than the rest of like their stomach and their abdomen area. The patient's position, we want to look to see if they're in that tripod position that we just talked about. And then if they are sitting with their feet dangling or leaning forward. The feet dangling is a way to not push pressure upwards. So it has a feeling of being relaxed. Okay. So we also want to look at what their work of breathing is like. Are they using retractions? Are they using their the muscles in between each rib? Are they retracting in? Are they using any accessory muscles like the sternocleidomastoid muscle that runs along the neck? Or are they using, or do they have any kind of nasal flaring or seesaw breathing or pursed lips or anything like that? And then we also want to look at how many words the patient can say without stopping. Can they speak in a full sentences, or is it every other word? We also want to look for pale cyanotic or flush skin, pedal edema, sacral edema, or oxygen saturation. So what we're looking for is this SpO2 of about 94%, okay, on the pulse ox. If we're looking at 94% or less, we're looking at probably some difficulty breathing. If we go farther on down, we're looking at, anything below 90, you're looking at like respiratory distress. And then when you get into like the mid 80s to low 80s, you're looking at probably respiratory failure. Okay. So that he's in this tripod position. He's got the barrel chest. You can see that this chest right here kind of looks like a barrel if you were to look at him head on. Kind of looks like he has a barrel chest. He's using the intercostal muscles here. Okay. He's also probably got some sternocleidomastoid muscle use going on here as well. He's in the tripod position. He's in respiratory distress, or at least difficulty breathing. So noisy breathing. So audible wheezing, heard without stethoscope, gurgling, snoring, crowing, stridor, or coughing. Those are all noisy breath sounds. Auscultating the lungs on both sides during inspiration and expiration. So we want to make sure that we listen to lung sounds on both sides. Okay. You've got lobes in your chest, you've got upper lobes and lower lobes. The best way to make sure that you listen for those lung sounds is up on the top near your clavicle, just below it. Listen for lung sounds up there. Listen for lung sounds on the sides, and then listen for lung sounds on the back as well. So wheezes are high-pitched sounds created by air moving through narrowed passages. These are typically like a lower airway type disease. Crackles are fine crackling or bubbling sound heard on inspiration, and it's caused by fluid in the alveoli or by opening of closed alveoli. Okay. Bronchi are lower pitched sounds resembling snoring or rattling caused by secretions in larger airways. So these are probably like your bronchi area. Stridor is the high-pitched upper airway sounds indicating a partial obstruction of the trachea or larynx. And we'll have I'll put some breath sound videos in here too. So in the online classroom. So evaluating vital sign changes. With difficulty breathing, any of these things can occur. Okay, they don't all have to occur at the same time. They don't all have to occur together. They can be separate. So increased or decreased pulse rate, changes in breathing rate, changes in the breathing rhythm, hypertension or hypotension, all of these things can show signs of difficulty breathing. Okay, so for patient care with difficulty breathing, we're going to make sure that we have adequate ventilations. If breathing is inadequate, then we're going to start with artificial ventilation. And if the breathing is adequate, we're just going to place them on a non-rebreather mask, or we're going to place them on a nasal cannula. Okay, because again, we don't want to over-oxygenate our patient or hyper-oxygenate them, so we're going to be cautious what we put them on. Okay, so use settings defined in your protocols. Typically, anything below 94, you're going to place them on a non-rebreather mask. If they can't tolerate the mask, then we're going to switch them over to a nasal cannula. However, you know, I start out on a nasal cannula if I can, and then if the patient is just obvious work of breathing, obvious respiratory distress, then I'm going to go ahead and place them on a non-rebreather. Okay. We want to place the patient in a position of comfort. Sometimes this comfort is whatever they can get into. They may not want to lay down. They typically want to sit up. They also, for like your CHFers who are having difficulty breathing, they want to dangle their legs on either side of the cot. So as much as possible, we want to be able to do that for them. Okay. Administer a prescribed inhaler, and then CPAP. Okay. So CPAP principles. So it's blowing oxygen or air continuously at low pressure into the airway, and this prevents the alveoli from collapsing. Okay. It can prevent fluid shifting into the alveoli from surrounding capillaries. CPAP, when we use CPAP, we use it for pulmonary edema, drowning, asthma and COPD, and respiratory failure in general. Sometimes we can use it as a way to prevent intubation or as an alternative to intubation. Okay, so some contraindications in CPAP. The patient has to be alert in order to use CPAP because they have to be able to breathe in. If they're not going to be able to breathe in, then CPAP isn't going to work for them. Okay. Lack of normal spontaneous respiratory rate. They have the inability to sit up because again, you have to sit up. You have to be able to be alert. Okay. Hypotension and shock are all contraindications of CPAP. Nausea and vomiting. Obviously, if the patient is nauseated and they're vomiting, then we don't want to put CPAP on them because CPAP is that mask that fits right over the face. You have to create that seal in order for CPAP to work. If they're vomiting, you're going to have to take off that CPAP all the time, and it's just not going to work. Okay. Penetrating chest trauma. We don't want to force air into the lung space, causing further damage because they have some type of penetrating chest trauma and they have that hole. Okay. Shock, upper GI bleeding, or recent gastric surgery. Again, what we're doing is we're not only forcing air into the airway, we're also forcing air into the stomach. Okay. And then any kind of condition that may prevent a good mask seal. Beards are sometimes a problem to create that good mask seal. So side effects of CPAP, we've got hypotension, pneumothorax, increased risk of aspiration, and the drying of the corneas. Okay. So we want to explain the procedure to the patient and start with low-level CPAP. Okay. Low level is 5. However, therapeutic level is 10. So we should really be starting on that 10 before 10 of the positive end expiratory pressure. So we want to make sure that we do a therapeutic dose. So we should be starting at 10, and if we need to work our way down, then hey, we can work our way down. But 10 is that therapeutic level. Okay. And then reassess the patient's mental status, vital signs, and dyspnea level frequently when we're doing CPAP, and then raise the CPAP if no relief within a few minutes. Okay. Continually reassess and monitor. If the patient deteriorates, remove the CPAP and begin ventilating our patient with a BBM. Okay. So let's talk about some respiratory conditions. Let's talk about COPD, or chronic obstructive pulmonary disease. It's a broad classification of chronic lung diseases. It includes emphysema, chronic bronchitis, and black lung. Overwhelming majority of cases are caused by cigarette smoking. Chronic bronchitis is when the bronchial linings become inflamed, they produce excess mucus, and the cell in the bronchioles that normally clear away mucus accumulations are unable to do so. Okay, so this is our normal one over here. And then we have chronic bronchitis, where we have these mucus plugs that form because the cells can't get rid of the mucus themselves. And then in emphysema, instead of like the mucus forming, we have decreased surface area in the alveoli, which means that if you don't have the space in the alveoli to get rid of everything, then to get rid of the carbon dioxide and make the exchange for oxygenation, then you'll have problems later on down the road. Okay. So in emphysema, the alveoli walls break down. The surface area for the respiratory exchange is greatly reduced. The lungs lose elasticity, and this results in air with carbon dioxide being trapped in the lungs, reducing that effectiveness of normal breathing. Okay, so asthma. We probably all know somebody with asthma. We probably all, maybe one or two of us, have had asthma before. I had it as a kid. It was just a pediatric asthma. I kind of grew out of it, so I don't have a whole lot of issues with it now. But it is a chronic disease with episodic exacerbations, meaning that patients will get an episode of asthma where the exacerbation is that what we typically think of as asthma. Okay, but it's there all the time. So during an attack, the small bronchioles narrow, causing bronchoconstriction. Mucus is overproduced, and this results in small airway passages practically closing down and severely restricting the airflow to the lungs. Okay, airflow is mainly restricted in one direction. In inhalation, expanding lungs exert outward pull and increase the diameter of the airway and allowing airflow into the lungs. On exhalation, the opposite occurs and the air becomes trapped in the lungs. So you can get the air in, you just can't get the air out. So pulmonary edema. This is the abnormal accumulation of fluid in the alveoli. This is mainly in CHF patients. You'll see it also in like right-sided heart failure, left-sided heart failure as well. and they may experience difficulty breathing because of this. So pressure builds up in the pulmonary capillaries, fluid crosses the thin barrier and accumulates in the alveoli. The fluid occupying the lower airways makes it difficult for oxygen to reach the blood. And the patient experiences dyspnea because the body's saying, hey, I'm not getting the oxygen that I need, so we need to do something, we need to figure it out. And the way it does it is by inducing difficulty breathing, causing the difficulty breathing. Okay. So common signs and symptoms of pulmonary edema. So they've got difficulty breathing, this dyspnea, anxiety, pale and sweaty skin, tachycardia, hypertension. Respirations are rapid and labored, and they have a low oxygen saturation. In severe cases, you can hear crackles and sometimes wheezes, and the patients may cough up a frothy, usually white, but sometimes pink tinged sputum. Why is it pink tinged? Because you've got blood crossing that barrier and getting into the lungs. Okay, so treatment, we want to assess and treat for inadequate breathing. We want to provide high concentration of oxygen, and if possible, keep the patient's legs in dependent position. So it's that position where they're dangling, okay? And then CPAP may be used to push the fluid back out of the lungs and into the capillaries. So it might be possible for a patient to have multiple might it be possible for a patient to have respiratory disorders, multiple respiratory disorders? Absolutely. Okay. Patients with COPD typically have like one or two of them, and it's typically chronic bronchitis and emphysema. So yeah, I mean, they do all the time. Okay. Could a patient with an underlying diagnosis of COPD also have pulmonary edema? Yes. Okay. COPD encompasses a wide variety of problems, and pulmonary edema is one of those things. Okay. Pneumonia. This is an infection in one or both of the lungs caused by bacteria, virus, or a fungi. It results from the inhalation of certain microbes, and those microbes then grow on the lungs and cause inflammation. When pneumonia occurs from an infection in the lungs, it can interfere with normal gas exchange. Yeah. So signs and symptoms of pneumonia: shortness of breath with or without exertion, coughing, fever, and severe chills, chest pain. It's often sharp and pleuritic. Remember, we've got the pleural space that surrounds the lungs and the chest cavity. So what happens is that there's a fluid in there that sits between those two pleurals in that pleural space. So you've got the visceral pleura and the parietal pleura, and what happens is there's fluid in there that prevents it from rubbing up against each other. And when that fluid is depleted, like in pneumonia, then you've got that friction that causes rubbing against those pleura together, and those pleura then create that pain. So some more signs and symptoms: headache, pale, sweaty skin, fatigue, confusion. I like to say that these patients sound crappy. They sound like they have like fluid. They may have some gurgling respirations, some gurgling sounds in the lower chest, the lower lungs. Yeah, they sound pretty crappy. Okay. So our treatment with pneumonia is mostly supportive. We want to assess and treat any kind of inadequate breathing. Okay. So if the patient is having that inadequate breathing, we're going to place them on a non-rebreather mask. We're going to ventilate them if we have to. We're going to try some various things and transport them. Okay. So spontaneous pneumothorax. This is when air builds up in the space between the lung and the chest wall, and that pressure that builds up can cause a collapsed lung. And it typically occurs when they don't have any other injury or anything like that. So it just happens, okay? So it typically occurs in tall, thin people, and smokers are at higher risk for this condition. Okay, so signs and symptoms of a spontaneous pneumothorax: sharp pleuritic chest pain, decreased or absent lung sounds on side with injured lung, shortness of breath, um, low oxygen saturation and cyanosis, and tachycardia. So treatment, transport to a definitive care facility. Um, these patients require some type of chest tube. Administer oxygen, and CPAP is contraindicated because we don't want to force air in because they've already got air inside the lung cavity. So if we're just forcing that air into the chest cavity, then it's just not going to work. So pulmonary embolism. This is blockage in the blood supply to the lungs. Okay, so there has been some type of arterial obstruction that prevents pulmonary blood flow. And then these blockages cause disruption in the lung tissue. Okay, it disrupts that perfusion in the lung tissue. It's commonly caused by a deep vein thrombosis. It has an increased risk from limb immobility, local trauma, or abnormally fast blood clotting. So, like, we want to, when patients go in for surgery, they go in for hip surgery or knee surgery or anything like that. They go in for some type of surgery. You see them and you're kind of mind blown when you hear that patient was up 3 to 4 hours after the surgery. What we're trying to prevent is the that thrombosis in that vein that's down there in that extremity that had surgery. We want to prevent blood clotting. So, and the way we do that is by mobility. Okay, so when that patient is up and walking around, their blood is moving and it's pumping. When that patient is not going and they're not moving that leg and they're not bending it or something like that, then the blood just kind of sits there and is stagnant. Even though it is moving, it's just moving really, really slow. So you have a higher risk for blood clots to form. And so what happens is that blood clot forms, let's just say the knee. So the patient had knee surgery. So that blood clot forms in the knee area, and then it breaks loose. It travels up to the lungs, because where does all blood flow go? It goes through the lungs, and it causes a PE. Okay. So signs and symptoms: sharp pleuritic chest pain, shortness of breath, anxiety, coughing, sweating skin, maybe pale or cyanotic, tachycardia, tachypnea, wheezing. This is probably the key right here, especially after a surgery. So a good assessment on your patient is key to figuring out what kind of chest pain this is, because it could be a PE. It's a sudden, sharp type of chest pain. And it typically only occurs when you breathe in with that chest pain. So treatment, it's difficult to differentiate in the field. So we're going to treat them like a chest pain or difficulty breathing or both, maybe. So we're just going to treat all of them just like that. Okay. Transport to definitive care and oxygenate them. If we have to, we can ventilate them as well. Epiglottitis, this typically occurs in children and infants. It's not something that occurs readily in the adult field or in the adult patient. Um, and what happens is there's an infection causing swelling around and above the epiglottis, that little leaf-like structure that covers the trachea. In severe cases, the swelling can cause airway obstruction. So it's the tissue around the trachea that's swelling and it's closing off that trachea. So with epiglottitis, you're going to have sore throat, drooling, 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 drooling. They're just going to have it. I mean, their tongue is probably going to be sticking out, and they're just going to be drooling all over the place. Okay. They prefer to be upright or in that tripod position. They have a sick appearance. They have a muffled voice, and then you'll also hear stridor, because remember what stridor is. It's that upper airway blockage of some kind. Okay? So treatment: keep the patient calm and comfortable. Do not inspect the throat. Administer high concentration of O2 if possible without alarming the patient, and then transport. Okay. Cystic fibrosis. It's a genetic disease that typically appears in childhood. Patients with cystic fibrosis don't live very long because there's really not a good treatment for them. And it causes a thick, sticky mucus that accumulates in the lungs and digestive system. That mucus can cause life-threatening lung infections and serious digestion problems. These patients are in and out of the hospital all the time. Years ago, they used to place you in like a vibrator, and it covered the whole chest. And what happened was it basically vibrated all of the mucus and broke it up. Signs and symptoms: coughing with large amounts of mucus, fatigue, frequent occurrences of pneumonia, abdominal pain and distension, coughing up blood, nausea, weight loss. So the caregiver is often the best resource for baseline assessment of the patient. Caregivers can often guide treatment, and they assess for and treat inadequate breathing. Okay. And then transport. Of course, place them on oxygen, give them as much oxygen as they can handle, and ventilate your patient if necessary. So viral respiratory infections, these are what we call like RSV. It's an infection of the respiratory tract, usually minor but can be serious, especially in patients with some type of underlying respiratory disease like COPD. Other ones, you're talking about SARS, avian bird flu, COVID-19, any of those things are viral respiratory infections. Okay, so often starts out with sore or scratchy throat, with sneezing, runny nose, and fatigue, fever and chills, and then the infection can spread into the lungs, causing shortness of breath. The cough can be persistent, and they may produce like a yellow or greenish sputum. All right, so the prescribed inhaler. This is a metered dose inhaler. It provides a metered, exactly measured, inhaled dose of medication. It's most commonly prescribed for conditions using bronchoconstriction. Okay, so that prescribed inhaler. So before administering the inhaler, we want to make sure that we have the 5 rights: right patient, right time, right medication, right dose, and right route. Check the expiration date, and then shake the inhaler vigorously. The patient has to be alert enough to use the inhaler, and use a spacer if the patient has one. So what that spacer does is that it allows for the medication to become a little bit more aerosolized, and allows for greater distribution of that medication in the lungs. Okay, so this is that spacer. To administer the inhaler, you want to have the patient exhale deeply. They've used one before, they should know, but you want to still coach them because they may have some anxiety about what is currently happening. So have the patient put their lips around the opening, press the inhaler to activate the spray as the patient inhales, and make sure the patient holds their breath as long as possible so the medication can be absorbed. Okay. This is an albuterol treatment. You'll see these patients will have these in their homes as well. So small volume nebulizers, medications used in a metered dose inhalers can also be administered by a small volume nebulizer. Nebulizing, running oxygen or air through the liquid, through liquid medication. And then the patient breathes in those vapors created. It produces a continuous flow of aerosolized medication instead of like the inhaler or that metered dose inhaler where you're just pushing it once and that's it. This provides a continuous flow of that oxygen or of that medication, and it just kind of gives that patient a greater exposure to the medication. All right, respiratory emergencies are common complaints for EMTs. It's important to understand the anatomy, physiology, pathophysiology, assessment, and care for patients experiencing these emergencies. Patients with respiratory complaints, closely related to cardiac complaints, may exhibit inadequate breathing. Rapid respirations indicate serious conditions, including hypoxia, cardiac compromise, and respiratory problems, along with shock. So very slow and shallow respirations are often the endpoint of a serious condition and are a precursor to death. Remember, those agonal respirations, those are not sufficient to support life. So when you have those very slow or shallow respirations, you're looking at like 8 times per minute. Those are agonal respirations. They're not sufficient to support life. And your patient's needs intervention as soon as possible. The history usually provides significant information about the patient's condition. In addition to determining the pertinent past history and medications, you want to determine the patient's signs and symptoms with a detailed description, including the OPQRST and your sample with the events leading up to the episode. Important physical examination points include checking the patient's work of breathing, inspecting accessory muscle use, gathering pulse ox readings, assuring adequate and equal lung sounds bilaterally, and examining for excess fluids. Lung sounds, does it sound like they have fluid in there? The ankles, the abdomen, do they have some type of pedal edema, or do they have like gastric distension causing with that fluid in the abdomen? And then gathering vital signs. So things to remember: you want to determine if your patient is breathing adequately, inadequately, or if they're not breathing at all. Choose the appropriate oxygenation or ventilation therapy. And then several medications are available that may help correct a patient's difficulty in breathing. We want to consider whether to assist a patient or administer respiratory medications. Do I have protocols and medications that may help with this patient? And does this patient have a presentation and condition that may fit these protocols? So are there any contraindications or risks to using those medications in my protocols? Okay, those are all things to consider. So some more questions to consider. Again, these are not assignments, but they are just things to think about when you're looking at respiratory emergencies. So what would you expect a patient's respiratory rate to do when the patient gets hypoxic, and why? Okay. What would you expect a patient's pulse rate to do when the patient gets hypoxic, and why? and then list the signs of inadequate breathing. Would you expect to assist a patient with their prescribed inhaler when they are experiencing congestive heart failure? Why or why not? And list some differences between adult and infant-child respiratory systems. Okay. All right, so let's go through this. A 72-year-old female complains of severe shortness of breath. Her husband notes she is confused. You note a respiratory rate of 8 breaths per minute and cyanosis. Patient has a history of COPD and CHF. Discuss the treatment steps to assist this patient. So she's altered. We could probably maybe do some CPAP, but it's not going to work because she's altered and she has a respiratory rate of 8. Again, 8 is not sufficient to support life in an adult, and she's already got cyanosis, so that means she's already blue. So we need to start doing something. We need to start fixing this. We need to start ventilating our patient and getting in there as fast as possible. Okay. And then after we've assessed and dealt with the airway, then we can do maybe a more thorough assessment and history. Okay. So again, if you have any questions, let me know. You can leave questions down in the comments or the discussion section. And then if you can also text me, email me, call me with any questions that you have, and I will do my best to answer those. And otherwise, I will see you on the next lecture.